Good evening, everybody. My name is Dr. Shabana Bora. I'm a gynaecologist and fertility specialist based in London. I'm currently an independent fertility specialist, but worked at one of London's leading fertility clinics for over 10 years. It's a pleasure to host the show this evening. So the purpose of today is really just for us to get together and talk about IVF add-ons and to see whether or not these might be beneficial to you, whether they might be of some form of harm to you. So it's just to sort of dispel any myths or questions that you might have. So I'd like to introduce, first of all, Federica Moffa, who's the medical director from Fertility in Spain, in Barcelona. Welcome, Federica, to the show. As well as 𝐬𝐮𝐬𝐫𝐿, who is also medical director, but in Greece from the embryo clinic. So we will start off by answering one of the questions which has already been sent yesterday. So this lady asks, I have had one chemical pregnancy, and then for my most recent transfer, we did an ERA to time progesterone, and I did a 𝐬𝐻 wash. The embryo failed to implant. Both were PGTA euploid embryos, and can you share more insight into the benefits of the immune protocol for frozen transfer when there is a known autoimmune disorder? She hasn't specified what autoimmune disorder she has, and is there any other testing you would recommend? So it's failed implantation of 2 PGTA normal embryos, both seem to be top quality, and she's had a chemical pregnancy despite having had an ERA and 𝐬𝐻. So is either of you want to start by answering this question?
Go ahead, Federica.
Of course, there is a big debate what we call implantation failure or repeated implantation failure, but here we have 2 very good embryos with PGTA normal embryos. So, and the patient did most of the tests that she could have done. We don't know what is this known autoimmune disorder. So I would suggest to maybe see an immunologist. Actually, we have in our clinic an immunologist that is specifically for those kind of cases. Sometimes the immunologist could suggest to test for 𝐬𝐻 profile, or to see if we can find some reason for this implantation failure.
Okay. Elias, do you have anything more to add about that particular case?
Sure. Yeah, I mean, I think Federica answered most of the topics, but I mean, my point of view is very simple. Firstly, PGTA normal embryo doesn't mean an embryo that's going to implant 100%. And I think we have to be very clear about that. DNA integrity is one part of the equation, and it's one element of a possibility of an embryo being able to implant. And I think we haven't communicated as doctors, as scientists, we haven't communicated that to our patients clearly. And I think this is one of the reasons why our patients are asking for PGTA, believing that this will solve all the embryo problems. That's not the case. So number one is this. Number two is that before we go into looking for fancy stuff like immunology, and very rightly, Federica, they have an immunologist on their team, so do we, because most things I don't understand as a gynecologist. So I need to ask my colleagues in a multidisciplinary meeting. But before we go into fancy stuff, I think we should exclude common
things, yeah.
Common failure etiologies like I mean, endometrium, standard endometrium. And again, I would like to make 2 points here. I believe that, and it's also written in the guidelines, both the HFEA and the ESHRE guidelines, that for repeated implantation failures, a hysteroscopy may be in order. So let's not forget the endometrium. Let's not forget big things in the endometrium, like adhesions, big reasons for failure. Adhesions, big fibroids, big polyps. And let's remember also number 2, and I will stop here, that traditional ultrasound, traditional two-dimensional ultrasound may not give us the full picture most of the time. So a very careful ultrasound scan of the uterus may give us more information than just a standard test. So I would like to conclude by saying that, if we hear galloping in our back, it's more likely to be a horse than a zebra.
Yeah, and I would agree with you, because I think there's a common misconception that if patients think that they have a PGTA normal embryo, then it's going to give them a 100% chance of it working. So then the next question is, well, why didn't it work? And if the embryo doesn't work, then there must be something wrong with me. And everybody is everyone talks about immune quite a lot and thinks that that's the magic answer. However, there are so many other things to take into consideration. And like you rightly said, things like, is the cavity all right? Is there any, form of endometritis or infection which might be causing the embryo to not implant or cause a biochemical miscarriage? So I think immune is not always the answer. And particularly in the UK, we're very careful not to jump into something like immune testing, particularly because some of the treatments for immune testing can be harmful and not always safe. And so that's certainly from my point of view anyway. Okay, so I know we before we joined the conversation, I think Elias, you wanted to talk more about PGTA. So obviously, there's a very, very long list of add-ons, but should we start then by talking about PGTA, because we don't have any questions at the moment. So what are your thoughts on PGTA? Do you think it should be offered to everybody? Do you think it should be offered to a cohort of patients who you think would benefit the most? And what do you do in real practice? Because certainly in the UK, it's definitely become more fashionable. So I just wanted to know your take on it from a Greek perspective.
Sure, absolutely. I mean, I have to say that, in my clinic, we apply a nice mix of international perspectives. I would probably say that due to my background, the majority is the UK guidelines that we stick to, but sometimes we enrich them with a little bit of European flavor. So I've been around, obviously, more than 30 years. So I've been through all the phases of PGTA. I believe that we were very fast to believe that PGTA, we as a scientific world, that PGTA was the solution to every problem.
Yeah.
Of course, we created more problems than we solved. Having said that, that has damaged, I think, the status quo now, because on one hand, we have the patients believing and thinking that perhaps PGTA is the solution to every problem.
Yeah.
Maybe our American colleagues are not helping very much in that, because they liberally apply PGTA, as we all know. Maybe right, but it's not.
And have done for years as well. I mean, there's definitely a trend to do it in the States, where it's largely split cycle and PGTA on everybody.
Sure. To be honest, I have always been guarded, because although I'm a surgeon in nature and in background, I've always been very conservative, and I was always very wary of the potential side effects or damage or unnecessary intervention, or unknown effects, future effects of the unborn child, or, if you like, the skill of our embryologists, because we've been through embryologists damaging embryos in the past and so forth. So my stance at the moment is very simple. PGTA is a very useful tool, and in my opinion, it should be used selectively.
Yeah, and so just to break that down to the audience, so primarily it's the concerns about the reliability or the accuracy of the PGTA, because you could be potentially discarding embryos which are deemed abnormal when they're actually normal, or they're deemed or the other way around, and the other is potential embryos which may then not survive a freeze, and then there's the time delay and the cost factor involved in doing PGTA. So that leads us on then nicely to the next question, which is, who would you not offer PGTA testing to? What would that patient be, or who would that
not offer PGTA on egg donation cycles?
Okay.
As there's a very clear possibility of abnormal sperm affecting the integrity of the DNA. I would be very skeptical, and I would probably not offer in Greece it's illegal to offer PGTA on egg donation
gender
samples on women under the age of 35 who haven't had more than 2 or 3 miscarriages and so forth.
Okay.
So I would only offer PGTA in a very high-tech setting by a very experienced licensed embryologist in a very high-tech environment, and only if there's an indication, which is either repeated implantation failures or miscarriages, or maternal. To me, the clearest indication is advanced maternal age, definitely over 40, perhaps over 38 as well.
And what about you, Federico, in Spain?
But I agree. It depends. In Spain, I think that most of the center apply PGTA when it's indicated. So I agree with Dr. Tzakos that the main indication is advanced maternal age, of course. Mm-hmm. Actually, in our real world, in our practice, we propose a PGTA to patient over 37. I mean, 38 or above, or in a repeated implantation failure or repeated cycle with miscarriage or severe male factor, because we found also that in fact sometimes in egg donation we applied for a severe male factor, and we found a high proportion of abnormal embryos in donors' eggs when the sperm is really pathological. But I agree that you have to have a very skilled biologist team that can guarantee a high survival rate of the embryos to the manipulation and procedure, because otherwise the benefits of the screening is not compensated with the risk of losing embryos to the procedure. And we all know that for many years we discarded embryos that were mosaics embryos, and in the end they probably would have give live birth. So you have to have very good and reliable technique for the PGTA biopsy and testing, and good indication. Yeah.
So I have a question then. So if a young patient comes to your clinic, let's assume she's 34, and she's likely to have, a really nice embryo for transfer and multiple embryos then for freezing. Do you approach the subject? Do you broach the subject of PGTA testing on any surplus embryos, or would you just say flatly, no, I'm sorry, it's not an option for you? Because then if the patient comes back for, let's assume she has then a negative pregnancy test, and she then has 5 embryos in storage which are untested, and then she's now then gone through maybe 2 or 3 frozen embryo transfers and then hasn't then got pregnant, she might then come back to you and say, well, doctor, what you didn't do is do what my friend did, who's a little bit older than me, and you didn't offer me PGTA, and I've now spent a lot of time and money in putting these embryos back. So do you give it as an option? Do you say, do you suggest it as an option, and then say, look, actually I wouldn't recommend it, but there is this option? Or do you flatly just say, no, we're not going to do that?
In Spain, we can apply PGTA to everybody if we want. We don't have restrictions. So I discuss with the patient. Of course, I put on the table the cost benefits to continue with single embryo transfer. It's true that we do single embryo transfer really to everybody. If the patient is very young and she had 5 blastocysts and she do just a first failure, of course, I will not agree to go for PGTA. She has a second failure and she has 3 embryo left. We discuss the cost benefits to sew those 3 embryos left and do PGTA, but with also the risk to lose embryos in the procedure. So we discuss with the patient. I don't just say you are 33 and we don't do PGTA, because if the patient, so I discuss with the patient, I would say.
Okay. Okay, so we haven't had any. Oh, I have a question. Okay, so I'm 45. I only have one blastocyst left. Does it make sense to do PGTA? I was advised no to biopsy, and there is now only one embryo. So I know what mine would be, but let me hear yours.
Sure. I mean, my advice on patients of a little bit more advanced female age, roughly over than 42, 43, is definitely always have a PGTA. And the reason why I do this is because I want to have a pragmatic picture of the chances of this particular patient or couple. So in that patient, my clear answer would be yes, definitely. And why is that? Because the chance of aneuploidy, the chance of an abnormal embryo is very high, could be as high as 80, 90%. And I would like to know that. In my opinion, failure is not the biggest complication on an advanced stage IVF patient. The biggest complication is a miscarriage, which has a risk, apart from the emotional risk, has the physical risk of damaging the uterus. So if it's a later miscarriage, the biggest complication is the birth of a child that's been undiagnosed with anomaly.
Chromosomally abnormal, yeah.
So for those patients, I'm very clearly suggesting PGTA on every single embryo before I transfer it to protect them from that risk.
I think this lady's already has an embryo in storage, so I think her question is whether she should thaw and biopsy and then refreeze. I don't think it's about creating anymore. So what she said is she only has one left. So my answer would be I personally wouldn't advise a thaw, biopsy and refreeze with a 45-year-old lady with one embryo left. I would feel that their body is the best gauge as to whether it's going to work, and then she can always have then prenatal testing. But what do you think, Federica?
I in between, let's say that, of course, when the patient step in, I would never had a patient 45 years old with embryo left without PGTA testing. But if it's the case, I agree with you that the cost of the risk to lose this embryo and knowing that the embryo will not implant is the highest probability is that the embryo will not implant. Or if there is a pregnancy, of course, the patient should be aware that she has a very high risk of miscarriage or the need for
an IPT or something.
Yeah. So again, I discuss with the patient, but possibly we leave nature doing its work and see what's going on. So this is a strategy because we have just one. If she had 2 or 3, of course, I would thaw the embryos to do PGT. But just one, we can leave Mother Nature to do her job. Okay, we maybe had some problem with the connection, but we have the question. So a patient is asking. Hi.
Appeared on the other side. Okay. Can you see the question, Federica? I can't see it. Oh, I can see the question now.
I see the question. The question is, when talking with a doctor, how would we know what is a good or bad PGTA? What does embryos grading mean? What is the minimum for a PGTA? Okay, so I think that the question is how is the result of the PGTA, of course, discriminating between euploid or aneuploid embryos, but of course we have the mosaicism that is in between. Shabana?
Yeah, my signal cut out. Sorry for that. So the next question is, when talking with a doctor, how would you know what is a good or bad PGTA?
So we were wondering, because I read this question, the time you reconnected, I read the question, and I think that the patient is maybe asking how we know which is a good result or bad result. maybe this is the question.
I think they're talking about reporting. I don't know if the person who posed that question maybe wants to rephrase their question, and I'll move on to the next one. What does embryo grading mean? What does embryo grading mean, and what is the minimum for a PGTA? Okay, yeah. Do either of you want to answer that? It's more of an embryology question, but do you want to answer that question?
Yeah, I think that the second question is what is the minimum quality in terms of morphology that will allow the embryologist to perform the biopsy and proceed with the PGTA analysis. So, of course, I'm not an embryologist, but we can say that a blastocyst should reach a certain stage of number of cells, of course, and a certain degree of expansion to make the embryologist able to do the biopsy without harm. So there is a certain degree of expansion, and the number of cells in the trophectoderm, in the external part, should have a good number of cells, and also the inner cell mass should be clearly visible. In terms of scoring, if we see in the Gardner score, probably the good quality embryos are the more likely to be biopsied. But we sometimes, our biologists, if they can biopsy an embryo with medium quality score, they will do it.
Okay, so we always do biopsy, for example, CC embryos as well. Do you do that?
CC, not always. So the biologists really, they have their criteria, but not always. Okay. CC, they're not always biopsied in our clinic.
Okay. So there aren't any other questions at the moment, but maybe we can talk about your opinion on endometrial receptivity and also microbiome testing. Is that something that you do a lot of, particularly 𝐸RA, Emma, Alice, or do you feel that they have, particularly 𝐸RA, do you think it's gone slightly out of fashion? What do you practice there?
Who's going?
Please go ahead.
Okay, I mean, personally, I've never used any of those tests, 𝐸RA, etc. I don't know if I was a little bit backward or if I wasn't convinced by data, so I have no experience personally. But now, as we all know, it's gone out of fashion, so I don't think there's any question about this. Now, with regards to other tests of the endometrium, I'm a huge fan of endometrium. I believe that we've neglected endometrioms. I think that this is our duty as gynecologists to claim back its importance. I think that, going back into the history of IVF, I think we've allowed our wonderful embryologists to dominate the scene of research. And as gynecologists, we haven't really, held our ground on exploring further the implantation areas, the endometrium, its immunohistochemistry, its integrity, its biopsy, and so forth. So to answer clearly, I believe that there is a place of microbiome testing. I even believe that there is a place of standard PCR testing together with biopsy. I really think that endometritis is something hugely neglected. Again, it's our responsibility as gynecologists and a little bit of responsibility of our histopathologists who are receiving the samples and are only reporting whether it's malignancy or hyperplasia or atypia. They haven't put this marker that costs a few quid to see, a few pounds to see, or euros for that matter, to see for endometritis and all that. So I believe, and of course this is not for everyone, but for patients with suspected endometrial damage, patients with miscarriages, patients with hysteroscopic surgery, patients with polyps, fibroids, patients with adhesions, patients with abnormal endometrium. I think we owe them some explanation and some answer.
Yeah, and I would say I would absolutely agree with you. So a microbiome MRCOG testing is currently not on the HFEA traffic light system, so it hasn't been addressed as such as an add-on in that respect. But certainly anecdotally, I've seen myself, patients who've had much successes through microbiome testing. And it's a fairly simple test to do. It doesn't cause a lot of harm, and the results certainly they do make sense. Just also, from our own unit data, it has been shown to increase live birth rates by almost 10%, just from the small studies that we've done in house. So, and what's your take on it, Federica?
Yes, of course, we are in Spain, so the home of ERA tests and endometrio and et cetera, et cetera. So I have to say that for many years we were doing. I was not a big fan, but of course, here was, after one implantation failure, immediately was recommended, and all the patients were asking, and so it was quite difficult to refuse. Now, of course, as you said, it's a little bit out of fashion, especially ERA. But I'm a strong believer in the microbiome and testing, because, and as Dr. 𝐾𝐨𝐧'𝐭 says, I think we subestimated the prevalence of endometritis, and because it's asymptomatic. We have many patients that sometimes even after delivery, I have patients that came back for a second child for the embryos from the same cycle, and after delivery, and maybe they have some surgery, we found out that the failure is related to endometritis.
So I think we're all on the same page there. The gentleman who asked the question before about the good or bad PGTA, I think his question was referring to how to interpret the report. I mean, I can answer that question in that I think we don't have to interpret the report, because it usually comes back fairly clear as to which embryos are normal and abnormal, and usually our embryologists are very good at guiding the patients and explaining those results. So the next question is, which additional tests would you recommend in patients with endometriosis? Are there any specific add-ons that you would suggest in a patient who has endometriosis?
Okay, if I can take this. I mean, first of all, depends on whether it's diagnosed or suspected. Many times patients come with a label of endometriosis and it's not proven. Some other times we think we have excluded endometriosis and there's endometriosis present. So I think endometriosis has to be taken very seriously, especially in view of the fact that perhaps 50% of our infertility patients may have some degree of endometriosis. As we all know, endometriosis may cause symptoms or may not cause symptoms. A symptom may be infertility, may be implantation failures through inflammation. It could be miscarriage or ectopic through tubal damage. So, how long is a piece of string? I think endometriosis has to be considered. And if we are to diagnose, thankfully, ultrasound scanning can be pretty accurate, not 100%, but very close to 100%. And if there's any doubt, then perhaps additional testing, MRI scanning, and even a laparoscopy.
Yeah. So the answer is that they're not referring to add-ons per se, or just in terms of further investigations for patients who potentially have endometriosis. And if you're going to investigate for endometriosis, or certainly pelvic endometriosis, then it's probably worthwhile, spending the time to have a hysteroscopy as well, because then at least then the cavity is normal. But certainly in the context of endometriosis, there aren't any specific add-ons that I would necessarily recommend, just because a patient has a diagnosis of endometriosis. Would you agree?
Add-on in terms of treatment?
Well, just as they're talking about add-ons, so IVF add-ons, which are things which are not in the patient's particular plan, but as opposed to, for me, certainly a hysteroscopy is not an add-on; it's a procedure.
Exactly.
Whereas add-ons are sometimes things, or treatments which are not necessarily evidence-based. So I think that's where it's coming from.
With endometriosis, sometimes we can decide to treat before an IVF treatment to put the patient under 𝐬𝐻 analogs for 1 month, 2 months, or normally those are patients that also have an associated adenomyosis. So, and the diagnosis is the first step, as we say. So really do a very good studiation, and also make sure that there is or not an adenomyosis associated. But as add-on, sometimes put the patient under analogs or pill, or a progestinic pill under progestinic to prepare before she will undergo a stimulation.
Yeah. So that's just in preparation for treatment, really.
Yeah.
So there's a question here. It's quite a long. I read some of it's in Greek. Thank you for this insightful session. I'd be grateful for your guidance for women over 45. Which add-ons have strong RCT evidence supporting their use? That's the first question. Then, is there a global standard or guideline for validation? What biomarkers or conditions justify using immune modulating add-ons? And could AI or data analytics help personalize add-ons for patients? So should we just start with the first one? Which add-ons have a strong RCT evidence?
Almost none. The short answer is almost no one.
Well, from a UK perspective, it's freeze-all, I guess, which is a big kind of conversation starter. So your views really on freeze-all. So freeze-on, for example, from an HFEA point of view, freeze-all is always a green light add-on for patients who have a risk of OHSS. But do you have any who might be at risk of OHSS? But are there any other ones that you can think of which have a very strong RCT evidence?
I would definitely say PGTA for over 45 years. Because this will guide us, and this will help us make an informed decision if we keep going, I think, or not, with own eggs. I think one of the challenges with women in this age group is that, especially the fertile ones, the ones who keep producing eggs, who keep producing good quality embryos, is how far do we go and when do we stop? And I think that the patients deserve to know the genetic integrity of the embryo. So I would definitely suggest PGTA tested on every single embryo before embryo transfer.
Okay. Federica, do you have any sort of do you know of any of that have strong RCT evidence that you can quote?
Because we're speaking about 45 plus years old women pursuing IVF. So if you ask me, in my real world, we don't do IVF when the patient is over 44. So actually, even if the ovarian reserve of the patient is very good, and of course, in the very exceptional case that we perform IVF in 44, 45 years old patient, PGTA is not only the only way to find out eventually a normal embryos and having a chance of success, but on the other hand is a way for the patient to understand that this is not the way that she could reach a pregnancy, and sometimes it's a strategy for the patient to understand that she probably need to go for egg donation.
Okay, and then the next question is whether there's a global standard or guideline for add-on validation.
Well, I mean, global standard, we can we always refer, especially in Europe, of course, to the 𝐸 guidelines.
Yeah.
And we can also look at the ASRM, but the 𝐸 guidelines are very well written and based on evidence, scientific evidence. So I mainly refer to the 𝐸 guidelines. A global standard, it doesn't exist to my knowledge.
Nope.
Scientific society are those where we can look at to have a guide.
What biomarkers or conditions justify using immune modulating add-ons? Immune modulating.
I will ask my immunologist.
We'll try to gloss over the topic of immune therapy.
Yeah, but I mean, it depends if, of course, there are two big conditions. I mean, one is where really the patient has an immune disease.
Autoimmune condition, yeah.
So we will use corticoids, we will use anticoagulant, we will use different treatment when the patient really has a proven immunology disorder or a phospholipid condition. But otherwise, there are very little evidence to use. Yeah.
And could AI
if I can make a short comment on that.
Yes.
Well, I suspect that you're referring, Helen, on referring to natural killer cells, perhaps, or uterine natural killer cells, or TNF factors, or antinuclear antibodies. So, you know, I would agree with Federica. You know, please let's remember that in the absence of a real autoimmune disease like lupus or scleroderma and all that, the chance of an isolated immune factor is extremely small. We can certainly investigate, but at the moment, sadly, the evidence is not there.
Yeah.
So, you know, we don't disregard, we don't discard those possibilities, but the chance is small in the absence of a real life immune disorder.
Yeah. And then could AI help personalized add-on selection, do you think, in the future?
I hope.
Okay, good. So we'll just go on to the next question. How often should one test for endometriosis? Once or more like every year? Once or more like every year again? Do you keep on testing for endometriosis until you find it, or do you just assume someone doesn't have it if you've not seen it?
But this is endometriosis or endometritis? Endometritis.
Because he's written endometriosis, but I think she might mean endometritis. They might be able to, let me just try and...
Because endometriosis, once you have the diagnostic and then maybe you do a follow-up, depending on where are the lesion, if you have ovarian cyst, but maybe the patient is referring to endometritis.
Okay, so there aren't any open questions at the moment. So we might just quickly talk then about DNA fragmentation, if that's something that you do a lot of there, and what indication do you have for DNA fragmentation? What are your thoughts about DNA fragmentation, and how do you manage it? Who wants to go first?
So we actually, in our practice, we really look at the masculine factor. So we don't neglect it, especially because we found patients with IVF failure that in the end comes to Spain for egg donation after many years of failures, because then we have an advanced maternal age factor, but we found that we have poor results with egg donors. So we learned that the male factor is very important to be tested. Of course, we will ask for DNA fragmentation in case of very poor sperm count of astenospermia. So we will ask for simple and double strain DNA fragmentation. And we have, of course, in the team andrologists. We have 2 andrologists in the team, and the patient will receive consultation and also antioxidant treatments. And in some case, we will perform sperm selection with microfluidic, and then we will do PGTA if the fragmentation is still
very high. Okay. Elias, what about yourselves in Greece?
Yeah, I agree 100%. We do exactly the same, but also perhaps we are a little bit cautious when we have unexplained infertility. Sometimes even with normal sperm, we may find abnormal DNA fragmentation. We value also the oxidative stress testing, because we found we do have a specific sperm clinic in our lab, and a biologist found a correlation, a future correlation of the performance of the sperm actually higher with the oxidative stress. And it's also very important for us. These are markers also for general health of our men, and because we're dealing more often with older men, seriously older, reproductively older men, 50, 55, 60. Yeah, for those, I think the relevance is even bigger. So again, I think just like us gynecologists having neglected the perhaps the anatomy of the women, I think the biologists, they have neglected a little bit the male factors.
Yeah,
and perhaps a wonderful message from this webinar would be, don't forget that biology is 50% male, 50% female.
Yeah.
So I'm very pleasantly surprised that Federica has 2 andrologists. Excellent. Perhaps we can recruit one of them for some online consultations, because here in Greece they're very rare.
Really?
Very few and far between.
There are lots in London, I must admit.
All right, oh, brilliant.
Very
Okay.
lucky, yeah.
I will call you up on that.
I just, again, yes, I totally agree. Also, in case of advanced paternal age, we actually presented in the IVIRMA Congress here in Barcelona a poster showing that the result of egg donation cycle are inversely correlated with paternal age.
That's a really interesting. Yeah. And I suppose that one particular instance that I always use DNA fragmentation is if someone's coming for an egg thaw, using, having frozen their eggs for many years, and that's their only chance then, because they have frozen eggs. And I will always by default get a sperm DNA fragmentation before thawing the only precious eggs that they have, because you don't want to make a mistake there. So I don't think you can argue not doing that at that point. So there's one question here from Moldova, and it says, we are considering fertility treatment options abroad and would like to ask, would it be possible to send 3 women from our country, all 45 and over, to your clinic for IVF treatment? We are interested in protocols tailored to
I'll take them, because in Spain they don't take 45-year-olds. On one condition, that
there you go, Helen. You've got
one condition, that you come with them, so that we can share the responsibility and the glory.
Okay, yeah, good. All right. Yeah, and certainly from our point of view, treating anyone over 45, they need a medical obstetrician review, ECG, mammogram. Just make sure that they're in good health for establishing pregnancy and continuation of a healthy pregnancy.
If I can make a comment here, Shabana, if you allow me. My wife is a birth surgeon, and she has threatened to divorce me if I put anyone through IVF, anyone, regardless of their age, over the age of 35, without proper birth screening. And can I share with you today, I think it's very important, that about twice a year we diagnose breast cancer through that screening in women less than 40 years old. So maybe the message is that, and I think this is what gives IVF a bad name, the fact that sometimes women are stimulated, they get pregnant, they breastfeed, and they have breast cancer undiagnosed. So maybe, I know this is against the guidelines in the UK. I know very well the guidelines in the UK. I don't know about Spain, the national screening guidelines, but if there's a message here for patients is that equally important with, for example, cervical screening prior to IVF, in my opinion, is breast screening, because although fertility hormones in pregnancy, they do not cause, they're not associated with breast cancer. However, pre-existing cancer, it could be
become more aggressive. So then the last question, I think, so we're going to need to wrap up now, is will AI be used to choose a patient protocol, like a stimulation protocol, do you think? So put in some data and then AI is going to tell you what's the best protocol for that patient.
In my opinion, definitely. And, you know, there's no doubt about that. And it's not going to take very long time. In my opinion, it will take less than 3 to 5 years. I don't know what Federica thinks.
Yeah, maybe less, probably less, but it's an algorithm. So what we are doing with experienced docs, so we look at AMH, we look at the age of the patient, we look of the anti-follicle count, we look at different data, and we put everything in our brain, and we, based on our previous experience, we set up a protocol, and it depends, again, which kind of stimulation we are, for which purpose we stimulate the patient, because it's not the same if I have a 32 years old woman that she wants to freeze eggs for vitrification, or a patient that she just wants to have a fresh embryo transfer. So it's depend, and if we put all those data in the artificial intelligence, they will come up with the perfect stimulation protocol.
Perfect. Okay. Well, thank you very much. I think we'll wrap up. Is there anything else anyone wants to add before we finish? No.
Well, if I can say thank you. Thank you, Shabana, for an amazing webinar, and thank you, Federica, for very
thank you very much. Thank you very much for joining me and having this insightful conversation this evening. If anyone has any further questions, they can always write in, on one of the channels. But otherwise, have a nice evening and good night.
Thank you to everybody that was connected, and for you sharing this nice webinar. Thank you.
Thank you. Good night. Bye-bye.
Bye.
Bye-bye.